Ocular and neurological roles of dysfunctional meibomian glands in long COVID patients, Part 1. These are notes for November 30th, 2023. This YouTube continues a discussion of COVID eye infections and how COVID eye infections can serve as the first step of an invasive COVID infection which spreads from the mucosal tissues of the eye into cranial nerves, and from the cranial nerves into the brain stem. This discussion was started earlier this year during the Arcturus COVID wave. On the lower left, you see a panel from a YouTube, Urgent Care Exocrinology, Endocrinology, and Immunology in the context of COVID eye infections. A URL to this YouTube can be accessed in the lower left of this slide. Before we begin, I encourage you to visit the URL in the upper left. This is a Google Docs folder which contains a PDF slide summary of this YouTube, as well as prior YouTubes. These PDF slide summaries contain active links to other YouTubes as well as references on PubMed as well as news reports. So in order to access the visual information referenced in this YouTube, these PDF slide summaries are of great utility. In addition, you will find references and concept photo montages archived here. You're welcome to download all of this material. Now turning to the issue of meibomian glands in the context of COVID eye infections. In the right portion of the slide, you see panels from a paper describing normal and diseased meibomian glands. The upper image shows the tubular arrangement of meibomian glands in the upper eyelid of a human. The eyelid has been folded upwards, so you're looking at the inner surface of the upper eyelid. So the meibomian glands are oil-secreting glands, and we will go into their physiology in more detail shortly. But note that these tubular oil-secreting glands are oriented towards the rim of the eyelid. Meibomian glands discharge their oily fluid through a port which appears as a hole in the rim of the eyelid. And so if you look at the rim of an eyelid, you will see a series of holes. These are the exit ducts, the exit ports for the meibomian glands in the upper eyelid. There is another set of meibomian glands in the lower eyelid. And you will also see a line of ports along the rim of the lower eyelid. Now note in the lower parts of this panel, you see morphologies of diseased or damaged meibomian glands. And we will discuss the importance of these damaged meibomian glands in the context of COVID eye infections. And to put that in a broader context, if you consider the Arcturus COVID wave, one of the hallmark features of it was the increased incidence of COVID eye infections. So some of the people who developed long COVID from the Arcturus COVID wave likely started with COVID eye infections, which subsequently spread to other portions of their body. In a YouTube which was recently posted on this channel, we discussed the invasion of COVID infections from the eyes to the brainstem. A URL to that YouTube is highlighted in green. Now, we will continue this discussion of ocular mucosa to brainstem COVID infections. So on the left portion of this slide, you see cranial mucosa and visceral mucosa. The term mucosa refers to moist tissues that form the linings of internal body organs. Mucosal is the adjective, so it's often stated a mucosal tissue. The noun mucosa refers to the tissue and its type. And so cranial mucosa refer to mucosa in the cranial regions, mucosa of the eyes, nose, throat. Visceral mucosa, pulmonary mucosa, as well as mucosa of the alimentary tract. These would be examples of visceral mucosa. The key concept illustrated in this figure is that COVID infections can spread from mucosal tissues, step 1, into cranial nerves, step 2, and from cranial nerves into the brainstem, step 3. In this YouTube, we will concentrate our discussion on ocular mucosa, mucosa of the eyes, and how a COVID eye infection can spread to the brainstem through one or several cranial nerves. I'd like to read the figure legend from this figure from a recent review published in 2022. Figure 2. Possible pathways by which SARS-CoV-2 enters the brain through other neural invasions. In addition to infection through the olfactory route, SARS-CoV-2 can also be transmitted through direct or indirect contact with the eyes and oral mucosa. SARS-CoV-2 may enter cells through receptors such as ACE2 on the nasal cavity, eyes, respiratory epithelium, lung parenchyma, that means the central tissue of the lung, not the epithelial mucosal layer, lung parenchyma, and gut, and in turn affect multiple cranial nerves, including trigeminal, optic, and vagus nerves. SARS-CoV-2 may infect nerve endings, be transported retrogradely, and spread to other regions via synapses. An important sidebar comment: the virions can be internalized into neurons, into their cytoplasm through endocytosis. At this point, the virion is inside a membranous organelle known as an endosome. And this endosome can be transported along microtubules through microtubule-based motors, which can move the virion inside its endosome from the periphery of the neuron, to its cell body, which lies near or within the brain stem. That is a discussion of retrograde axonal transport. So now let us look at the starting point of a ocular COVID mucosal infection. So the various tissues that form the ocular surface interact with exocrine glands, glands that secrete fluids to the surface of an epithelium, in this case the ocular epithelium, the corneal surface. One such gland is the lacrimal gland, also known as the tear gland. And these tubular glands that are aligned along the rim of the eyelids, these are the meibomian glands. But what is a meibomian gland? A meibomian gland is an exocrine gland. And as mentioned, an exocrine gland secretes its materials, often fluids containing various solutes, to the surface of an epithelium, in this case the ocular epithelium. Now the product secreted by meibomian glands is an oil fluid, an oil film. And this layer of oil rides on the surface of tear fluid, which is an aqueous layer of tear components, including proteins, sugars, electrolytes, cell messengers, cytokines in case of an inflamed eye, as well as enzymes, and of course, water. This is a cross-sectional view of the tear film. At the bottom of this, on the surface of the corneal epithelium, is a layer of it's a hydrogel made from a mucopolysaccharide known as mucin. Mucin is secreted by specialized secretory cells in the corneal epithelium known as goblet cells. In addition, surface epithelial cells of the cornea also secrete mucin. This mucin is hygroscopic, meaning it absorbs water very readily, and by absorbing water, it becomes hydrated to form a hydrogel. Tear fluid and the mucin hydrogel play critical roles in the innate immunity of ocular tissues. The tear fluid is approximately 3 microns thick, and the tear fluid has a volume of about 3 to 10 microliters. This is a very small amount of fluid. What prevents it from rapidly evaporating? This evaporation is attenuated by a thin oily film which is secreted by meibomian glands. Again, these are the tubular exocrine glands that are aligned vertically in the upper and lower eyelid. They secrete the oily substance that mixes with tear fluid. The ports of the meibomian glands are along the rims of the eyelids. So tear fluid and the oily film that prevents tear fluid evaporation are very important for resisting microbial infections, particularly airborne microbes, bacteria and viruses, and fungal spores that frequently land on the ocular surface. In fact, tear fluid contains enzymes which help inactivate these microbes before they can infect cells of the ocular tissues. So what happens when these defense systems fail? And these occur when people have difficulty forming adequate tear fluid, and there is inflammation and damage occurring to various portions of these ocular tissues. This is known as dry eye disease, or DED. Let us put this physiology and anatomy in the context of COVID and long COVID. Dry eye disease is quite common in long COVID patients. In addition, approximately 70% of healthcare workers have reported new dry eye disease symptoms during the pandemic. Dry eye symptoms among healthcare workers has been attributed to frequent, prolonged mask wearing. Alternatively, some of these dry eye conditions may be associated with subclinical COVID eye infections. We will examine those issues later in this YouTube series. For the moment, before discussing the origins of the name meibomian gland, I'd like to review its anatomical structure and basic function. On the lower right of this slide, one sees a stylized diagram of a meibomian gland. Note that it has a central duct, which receives oily material secreted by numerous secretory elements. This oily material is passed to the exit port of the gland, And recall that exocrine glands secrete fluids to the surface of an epithelium, in this case, the rim of the eyelid. And here, this oily material, known as meibum, combines with tear fluid and thus forms an oily film that reduces evaporation of the tear fluid on the surface of the eye. I would like to pause here briefly for a sidebar comment. It pertains to the diversity of nomenclature of anatomical and physiological processes. Also, I apologize for my pronunciations of certain terms. I find it difficult to say the word meibum. Instead, I utilize the term oily film, which could be considered to be ambiguous by, say, ophthalmologists who study this in the context of clinical practice. Another difficulty in terminology, I use the term secretory duct to describe the central duct of this exocrine gland. In the diagram, it is labeled as an excretory duct. Some people might find that term confusing. For instance, a nephrologist, a kidney doctor, who is used to using the term excretory duct to describe nephrons and ureters. And so emphasizing a flexible epistemology in receiving and transmitting terminologies is very important, particularly as we discuss histopathogenesis in the context of COVID and long COVID. With that said, the basic takeaway message here on this slide is that we are dealing with exocrine glands. And to understand long COVID, it is necessary to understand the exocrine gland involvements and damages to exocrine functions. So collectively, this is known as exocrinology, and I will bring up this term repeatedly. The exocrinology of COVID and the exocrinology of long COVID. So going back to this question, what is a meibomian gland? Let's start with the name. Where does the name come from? Meibomian glands were first mentioned by Galen, who was the physician to the Roman Emperor Marcus Aurelius. This was circa 200 of the Common Era. The first published depiction of the meibomian gland was published by Johann Heinrich Meibom in the late 1600s. Meibom was a German physician and scholar, and it's because of this publication that the gland is named after him. Now, a sidebar comment on how this name was derived. Note that the German pronunciation of this individual is Johann Heinrich Meibom. In the late 1600s, the language of science and mathematics was Latin. And that was because world scholars needed a common language in order to be able to communicate. This was especially true for the emerging modern fields of medicine and anatomy. And so scholars published utilizing Latinized versions of their name. So Johann Heinrich Meibom published as Johannes Heinricus Meibomius. So the term meibomium is a Latinized way of expressing an adjective, the gland of Meibom. Now, another exocrine gland that we are discussing is the lacrimal gland, also known as the tear gland. Like the meibomian gland, the lacrimal gland is an exocrine gland. Lacrimal glands and meibomian glands work in tandem to create tear fluid, which contains an oily film on its upper surface This combination tear material provides some of the innate immunity to prevent the ocular surface from being infected by numerous types of pathogens. Where does the term lacrimal come from? Lacrimation is derived from lacrima, which is Latin for tear, and essentially means production of tears, although it is often used to describe the shedding of tears or to cry. Lacrimation refers to the process, the physiological action of the lacrimal gland. And that is similar to other exocrine gland actions, such as salivation, the action of the salivary gland, also known as the parotid gland, which secretes an exocrine fluid, the saliva. Similar terms are used to describe the function of the mammary gland, lactation. And so the description of exocrine gland actions has to be folded into the analysis of pathophysiology of COVID and long COVID, particularly because COVID-2 invades mucosal tissues and is able to penetrate into the ductwork and parenchyma of exocrine organs. By doing so, sets up cryptic sites of infection. And it is important to emphasize that exocrine glands are a known reservoir of COVID-2 infection, which persists in long COVID patients, also known as PASC patients, post-acute sequelae of COVID. It is already known that lacrimal glands can become long-term reservoirs for COVID-2 infection. The same is true for salivary glands. However, I have not found any publication on COVID-2 infections of meibomian glands, and that is still an open question. However, at this point in time in the pandemic, we should recognize that virtually all cells have ACE2 receptors, as well as other receptors that can bind and help internalize COVID-2 virions. And so it should not be a surprise if meibomian glands are found to be infected by COVID-2. Now the key issue is, how can the infections of these exocrine glands be eliminated, if that is indeed possible? And we will advocate for the stimulation of vitamin D receptors as a potent way of activating innate and adaptive immune responses in COVID-infected and impacted tissues. In discussing the innate immunity of mucosal tissues, it is very important to anchor those discussions in anatomical terms. This brings up the continued difficulty of differences in terminology, nomenclature, and the semantic drift of concepts. For instance, the term tear gland, which is an alternative term for a lacrimal gland, if you translate that into a language like German, the word is Tränendrüse, which means tear gland compressed into a single word. Johann Heinrich Meibohm would probably recognize Tränendrüse as tear gland, where it is possible that he would be unable to recognize the term lacrimal gland, which has been agreed upon through international convention. So there is a difference between the nomenclature used in conventional conversational language and the type of language is used in medical communications. In comparison, the term meibomian gland, the current German term for this, is Meibohm-Drüse, Meibohm gland. The Latinization of the name meibome has been compressed out of this. And so the technical term for meibomian gland is likely to vary within different language groups, which is a communication barrier in the discussion of COVID and long COVID, how we conceptualize and describe these anatomical structures. At the lower right of the slide, I'll emphasize this concept in more detail. The meibomian gland is composed of an array of secretory units called acini, which is a Latin term. The singular term is acinus. The terms acini and acinus are recognized by scientists who work on exocrine glands. However, these terms may be unfamiliar to many medical practitioners and certainly many patients. And yet, the acini are likely to be places where CoV-2 becomes enlarged and becomes a reservoir in long COVID patients. So the future discussions of long COVID will need to incorporate terms like meibomian gland acini and the scientific analysis of singular units, the meibomian gland acinus, how it is infected, the type of pathogenesis that occurs in this compartment, and how it can be medically treated. So what type of terms can be used to dialogue about these important issues with members of the public and more generally within scientific, medical communities, including people who are key COVID communicators? The phrase oil glands of the eyelid is a good alternative to the scientific terminology meibomian glands. So throughout this presentation and future YouTubes, we will use these terms interchangeably. The purpose of this is to increase the receptive vocabulary of a wide audience. It is first important to recognize that the meibomian gland is an exocrine gland, and because it is directly accessible to visual observation, it serves as a useful system to analyze the effectiveness of various COVID interventions. Before discussing the roles of meibomian glands in COVID infections, as well as treatments for COVID infections of the meibomian gland, let us briefly review some of its biological activities. On the right side of this slide, you see three panels. These are histological sections of meibomian glands, and the upper panel shows the gland secreting an oily cellular material from the right to the left. The type of secretion taking place in the meibomian gland is called holocrine secretion. Holocrine secretion is a specific mode of secretion involving secretion of entire cytoplasmic materials with remnants of dead cells. This is observed in multicellular exocrine glands of reptiles, birds, and mammals. The meibomian gland is a specialized sebaceous gland, an oil-secreting gland. Sebaceous glands are found throughout the integument of the human body, including, in this case, the eyelids. In the upper right, one sees a stylized diagram of a maturing holocrine secreting cell. One sees cytoplasmic materials, in this case oil, accumulating within intracellular vesicles, and then at some point the filled cell ruptures, discharging this cytoplasmic material, and the cell dies in this process. In the right-hand portion of the slide, the upper panel shows this process of cellular apoptosis, releasing cytoplasmic materials, and this cytoplasmic material with cellular debris is being discharged to the left. This is a meibomian gland acinus, a single secretory compartment. In the lower part of the slide, you see meibomian gland acini, which is plural. And you can see at lower magnification an array of acini, each discharging oil material with cellular debris into the central collecting duct of the meibomian gland. Now let us talk about what would happen if the meibomian gland becomes infected with a virus such as COVID-2. Placing the viral infection within this tissue compartment, the meibomian gland, as a human eye becomes infected with COVID-2, the conjunctiva, the mucosal tissues that form and surround the ocular surface will be places where COVID-2 virions are going to be produced. So at this point, virions will come in contact with the eyelid surface, and it is most likely that the initial infection of a meibomian gland would begin at this location. Once epithelial cells near the orifice of a meibomian gland become infected, the infection could spread from cell to cell along the collecting duct into ductules which connect to acini. And these acini could then transmit the infection to the surrounding parenchyma, which lie to the outside of the secretory epithelium. This is very important to consider because it is in the parenchyma of the meibomian gland that nerve endings, parasympathetic nerve endings, from the facial nerve, more specifically the parasympathetic fibers coming from the greater petrosal nerve, cranial nerve 7, make synapses on the epithelial cells of the acini. So if the nerve endings become infected, they endocytose virions from this infected meibomian gland, they could transmit the virions through axonal transport retrogradely towards the brainstem, arising first at the pterygopalatine ganglion. So the infection of mucosal tissues, step 1, followed by an infection of peripheral nerves, step 2, is followed by an infection of the central nervous system, in this case the brainstem, which is step 3 of this progressive COVID infection. So eye to brainstem infections involves a step where the exocrine fluids of the eye are critically involved. For that reason, it's important to understand the immunoexocrinology of COVID and long COVID, and this means understanding the immunoendocrinology of mucosal tissues and the exocrine fluids in particular. Besides the meibomian glands, the other exocrine glands that produce tear fluid are the lacrimal glands. It too, again, is an exocrine gland. So besides providing the fluid which COVID virions utilize to move through hydraulic forces, meibomian glands and lacrimal glands can serve as COVID-2 reservoirs in long COVID patients. And these potentially could be giving rise to ocular mucosa to brainstem COVID infections for days, months, or even years. During the Arcturus COVID wave, I reviewed literature and news reports pertaining to COVID eye infections, and I juxtaposed this information with published literature on the use of vitamin D receptor agonists. These are corticosteroids, vitamin D related compounds that can stimulate vitamin D receptors into activity. And so there are 4 parts to this discussion. The URLs to those YouTubes are highlighted here. Again, if you download a PDF slide summary of this talk from the Google Docs folder I referenced at the beginning of my talk, and it will also appear at the end of this YouTube, I encourage you to download this PDF slide summary because it contains these active links. I would now like to put COVID eye infections in a broader context. In the remaining portion of this YouTube, I will provide a set of links to news reports and publications and YouTubes, which will allow you to access lateral information. Earlier this year, during the Arcturus wave, these news reports appeared. Conjunctivitis, the new COVID symptom, and it can be serious. And as we will see, it may be an early sign of an incipient COVID brainstem infection. This is a very recent news report. Double trouble, navigating flu season's surprising companion, pink eye. Respiratory viruses like the flu and even COVID can cause pink eye. Here are tips for relief. Prior COVID infections by damaging meibomian glands and or lacrimal glands could make eyes more susceptible to COVID-2, influenza, and RSV. So it is very important to recognize that the prevalence of circulating respiratory viruses during the winter months, the eyes are particularly vulnerable to infection. Let us now discuss the potential for a COVID eye infection to spread to the brainstem. Again, there are 3 cranial nerves which innervate the eye. Cranial nerve 2, the optic nerve, cranial nerve 5, the trigeminal nerve, and cranial nerve 7, the facial nerve. Let us concentrate on cranial nerve 5 and 7, which innervate mucosal tissues of the eye. These are the tissues that are most likely to become infected initially by airborne droplets coming in contact with the eye surface. Once a COVID eye infection is established in the mucosal tissues, the virus can replicate. These virions could be internalized by endocytosis into fibers of the trigeminal nerve or facial nerve, and then moved retrogradely through axonal transport towards ganglia that lie next to the brain stem. We will discuss those in anatomical detail later. So in this stage 2 of the infection, we've moved from a mucosal infection, stage 1, now to a cranial nerve infection, which is stage 2. With time, the virus could be transmitted either directly along the axons to the brainstem, or it could replicate within cranial ganglia, amplifying its numbers, and then those virions transferred to the brainstem, causing this 3rd stage, stage 3, of the COVID eye infection. So COVID-2 invasion of the nervous system from the eyes. I've taken this figure from a paper which does not pertain to COVID eye infections, but I've added some extra information for clarity. So let's take a look at stage 1, a mucosal ocular infection be established. Then, as virions are internalized into cranial nerve fibers, cranial nerve 5, in this case, this is cranial nerve 7, and one branch of it is known as the greater petrosal nerve, which innervates the tear glands, lacrimal glands, as well as the meibomian glands. So at this point, it's moving through the greater petrosal nerve within endosomes, and then it would arrive at the sphenopalatine ganglion. The sphenopalatine ganglion is also known as the nasal ganglion. It is also known as Meckel's ganglion, and it is also known as pterygopalatine ganglion. In discussing the invasion of a COVID eye infection into the central nervous system, one could define the arrival of virions at the sphenopalatine ganglion as step 2A. Step 2B could be used to describe the further movement of virions beyond the sphenopalatine ganglion. The greater petrosal nerve, which is considered to be a branch of the facial nerve, the greater petrosal nerve will converge with other branches of the facial nerve, cranial nerve 7, and it is in this transit from the sphenopalatine ganglion to the brain stem, which could be referred to as step 2B. Once it arrives at the brain stem, one could refer to that as step 3. This would be step 3 of a COVID to brainstem infection. So now a question can be asked, putting this in terms of a clinical perspective. At what point in this COVID eye to brainstem infection could Paxlovid be expected to be effective? Can Paxlovid arrest an ongoing COVID infection during its cranial nerve phase? And that means while the virions are being transported from the eye tissues to the brain stem. So it appears the answer would be yes and no. Paxlovid would be expected to attenuate COVID replication within cell bodies, for instance, within the sphenopalatine ganglion. The no part would be during the transit within the axons, because the virions are not replicating while they're being transported within endosomes. That statement is, of course, an interpretation. A better way to reformulate these issues is to ask very specific questions, such as, can Paxlovid inhibit or eliminate CoV-2 virions within endosomes? If the answer is no, there are major ramifications for that answer. For instance, how could Paxlovid be expected to eliminate CoV-2 infections within nerve compartments? How could Paxlovid be expected to block the transmission of infection to the brainstem? If one concludes that Paxlovid can work while virions are replicating within ganglia, that changes clinical perspectives because there is an opportunity, a time window, where an inhibitor such as Paxlovid could be applied to block the amplification of virions within the peripheral nervous system. Once again, it is unlikely that Paxlovid could eliminate virions that are being moved within endosomes. However, it's possible that Paxlovid could block or attenuate the replication of these virions once they reach the cell bodies of the neurons located in the cranial ganglia. So simplifying this discussion to the following question. Can Paxlovid arrest a COVID infection during its cranial nerve phase? This is step 2. While the virions are moving through the peripheral nervous system and perhaps being amplified within the peripheral nervous system. So placing that question in the context of this earlier summary figure. Stage 1, mucosal infection. Stage 2, cranial nerve infection. Stage 3, brainstem infection. Note that there are a variety of routes for COVID infections to move from mucosal tissues to the brainstem via cranial nerves. Let us focus first on the respiratory system. The respiratory tract is divided into 2 main parts. The upper respiratory tract, consisting of the nose, nasal cavity, and the pharynx, and the lower respiratory tract, consisting of the larynx, trachea, bronchi, and the lungs. Cranial nerve 5, the trigeminal nerve, as well as cranial nerve 9, not shown, which is the glossopharyngeal nerve. These 2 nerves innervate the oropharyngeal cavity, which is a key locus for COVID infections, initial COVID infections. Below that panel of the face and neck is a diagram showing elements of the lower respiratory tract, the bronchial epithelium as well as the lung tissue, both of which have cells which express ACE2 receptors, which facilitate the entry of CoV-2 virions into cells. Looking at this overall diagram and thinking about the kinetics and kinematics, the movement of COVID virions from mucosal tissues into the brainstem via cranial nerves. How fast does this occur? So in the panel showing the profile of the head and neck, here the oropharyngeal cavity as well as the pharynx, these tissues are innervated by the trigeminal nerve, cranial nerve 5, as well as cranial nerve 9, the glossopharyngeal nerve. The glossopharyngeal nerve in particular innervates the adenoids, the epipharyngeal tonsils. So oropharyngeal infections, nasal cavity infections, occur very early on during a COVID infection. So the launching of virions into cranial nerves 5 and 9 is likely to take place fairly rapidly. Once a COVID infection migrates and is established within tissues of the lower respiratory tract, here virions could be launched into fibers of the vagus nerve. Now the vagus nerve, cranial nerve 10, is much longer, so one would anticipate a longer transit time for virions to move from pulmonary tissues to the pulmonary plexus, and from the pulmonary plexus to the lower part of the brainstem, the medulla. So again, can Paxlovid arrest a COVID infection during its cranial nerve phase? It of course depends on which cranial nerves are involved and whether the Paxlovid is being applied during a time window where there is replication of virions taking place within the peripheral nervous system. These are complicated questions that must be addressed through kinetic and kinematic analysis. But it brings up an important point. The cranial nerves, viewed as a compartment, quote, compartment, these cranial nerves serve at least as a temporary reservoir for CoV-2 virions. An important issue from a medical perspective, taking swabs of the oropharyngeal cavity or the back of the nasal cavity, the adenoids, this only gives a very superficial view of a propagating COVID infection. namely the mucosal phase. It's not surprising that the mucosal infection is cleared within 5 to 10 days. However, we now know that the mucosal phase was merely a period of time to generate virions which could be launched into cranial nerves, which cannot be sampled through nasal swabs, nor would these virions be detectable in serum. And yet, they are moving in endosomes towards cranial ganglia and eventually the brain stem. And this brings up the issue of reservoirs, and it has taken some time and a great deal of advocacy by long COVID patients and researchers to establish the concept of SARS-CoV-2 reservoirs. These are potential drivers of inflammation and other disease mechanisms in long COVID patients. And I encourage you to view this YouTube by Dr. Amy Proal, and there's an associated Nature immunology paper which this YouTube refers to. Above that is a paper, a preprint. This was a preprint as of January 2023. Long COVID brain fog and muscle pain are associated with longer time to clearance of SARS-CoV-2 RNA from the upper respiratory tract during acute infection. One of the key set of detectors of SARS-CoV-2 RNA are toll-like receptors. And the bottom part of the slide, you see two specific toll-like receptors, TLR7 and TLR3, toll-like receptor 7 and toll-like receptor 3. They respond to single-stranded viral RNA and double-stranded viral RNA, respectively. Toll-like receptors set off inflammatory responses which bring cells and tissues into states of inflammation. They are an important part of the early inflammatory response, and they are also known to participate in prolonged inflammation. So as long as foreign antigens, pathogenic antigens, and these are known as PAMPs, pathogen-associated molecular pattern molecules. These are the receptors, among the receptors that are activated by PAMPs. One way to attenuate the activity of these toll-like receptors is through a pan-specific toll-like receptor attenuator, naltrexone, and it is given in doses about 1 to 6 milligrams per day. And at that dose, it is commonly referred to as, quote, low-dose naltrexone. Low-dose naltrexone is able to attenuate toll-like receptors that are present on the cell surface, as well as toll-like receptors which are contained within endosomes. And it is in this latter compartment, endosomes, that the utility of low-dose naltrexone is manifest, because in virally impacted tissues, besides the virions, fragments of the virus, including single-stranded RNA, double-stranded RNA, in the case of COVID-2, spike protein, envelope protein, membrane protein, numerous toxic molecules are present which can activate different toll-like receptors. So having naltrexone within endosomes is an important way to attenuate hyperinflammatory responses. Among the many toxic molecules produced by COVID infections, let us focus attention on the COVID-2 RNAs, which are likely to be endocytosed and placed within endosomes. In the endosomal compartment, they are very likely to activate toll-like receptor 3 and toll-like receptor 7. As these endosomes with activated TLRs are transported retrogradely by microtubule-based transport, this is called axonal transport, and the endosomes are moving from the periphery of the nerve, the neuron, to the cell bodies located within cranial ganglia. During this transit, the pro-inflammatory signaling from these activated toll-like receptors are likely to produce inflammatory responses not only in the neurons but in neighboring glial cells. And this state of inflammation of the nerve is called neuritis. So what we're speaking about is a neuritis of a cranial nerve. In this YouTube, we have focused on two cranial nerves which innervate the mucosal tissues of the eye, cranial nerve 5, the trigeminal nerve, and cranial nerve 7, the facial nerve. Both of these cranial nerves are capable of transmitting a COVID infection from ocular mucosa to the brain stem via axonal transport of endocytosed virions. I would like to pause here for a sidebar discussion on the relative risks of COVID eye infections. There are many layers to this issue. For instance, what is the relative risk of acquiring a COVID eye infection? For instance, how frequent do COVID virions land on the ocular surface? How frequently do these virions establish an active COVID infection within the mucosa of the eye? And how frequent is it that virions from ocular infections are transported intracranial nerves and from there into the brain stem? One of the difficulties in assessing these risks is the changing susceptibility within human populations or within given individuals. This is because the susceptibility to infection has dramatically changed during the pandemic. For instance, with immunization or natural infections, the susceptibility to infection or severe disease has been changing. It goes up and down with waxing and waning immunity. But I also like to add, there's another factor that needs to be considered. Prior infections create damage to these mucosal tissues. Mucosal tissues generally have a great deal of regenerative ability compared to, say, neurons. Neurons can regenerate their processes, but if you kill a neuron, there is very little chance that the nervous system would be able to replace that neuron from, say, neuronal stem cells. In the case of COVID infections, there is another source of threat, and that is the reactivation of dormant pathogens such as herpes viruses. Herpes viruses tend to infect nerves as well as certain types of immune cells. So the reactivation of herpes viruses, if the infection is then carried to the ocular tissues, this could dramatically increase the susceptibility of the eye to additional COVID infections. Let us take this concept and put it in the context of recurring COVID infections. Talking now about the Arcturus COVID wave, which appeared earlier this year, XBB 1.16. This news report was posted in the spring of 2023. Conjunctivitis, the new COVID symptom. However, conjunctivitis, even though it is more prevalent with Arcturus and related subvariants, conjunctivitis has been present from the earliest days of the pandemic. It is just now more frequent. Part of this is probably connected with characteristics of the new subvariants. However, the issue of susceptibility also needs to be examined. For instance, did prior COVID infections occurring in the winter months of the transition from 2022 to 2023 make certain individuals more susceptible to Arcturus eye infections. Going to the left-hand portion of the slide, this concept, long COVID brain fog and muscle pain are associated with longer time to clearance of SARS-CoV-2 RNA from the upper respiratory tract during acute infection. So the accumulation of COVID-2 RNA in various tissues has been associated with neurological conditions. Is it possible that RNA, which accumulates in the conjunctiva of the eyes, remains for weeks or months, making those tissues more susceptible to subsequent COVID infections? This question could potentially be addressed by looking at epidemiological information about COVID eye infections, as well as case study and case series reports of people who have recurring COVID eye infections. In summarizing this YouTube, it is important to connect certain key concepts. We have been discussing COVID eye infections and how these eye infections can spread to the central nervous system. So we have been discussing COVID infections of ocular mucosa and how they spread to the brainstem. In this process, several glands and tissues can become infected. These include the meibomian glands, the oil-secreting glands of the eyelid, the tear glands, known as the lacrimal glands, as well as cranial nerves. So all of these organs, tissues, serve as at least temporary COVID-2 reservoirs. It is an open question how long these infections last. It is very possible that in long COVID patients, one or more of these compartments maintains persistent COVID-2 infections. And this connects to concept number 2, SARS-CoV-2 reservoir, tissue reservoirs, glandular reservoirs. These are potential drivers of inflammation and other disease mechanisms in long COVID patients. This connects to concept 3, an important new terminology for discussing these chronic conditions. It is called IAC, an abbreviation for infection-associated chronic condition. Various etiologies can produce an IAC, an infection-associated chronic condition. These may be sequelae to viral infections, a post-viral chronic condition. They may be a post-infectious condition, so besides viruses, other infectious agents, bacteria, protozoa, fungi, can all produce long-term chronic conditions. Examples, Lyme disease. Post-treatment, the use of therapeutic agents such as high-dose steroids can impair mitochondria to produce critical hormones such as calcifediol and calcitriol, which stimulate vitamin D receptors. So the use of a steroid like dexamethasone, which is a, quote, vitamin D disruptor, can produce long-term changes in mitochondria which impair their ability to maintain these local production of immune hormones. And this could lead to local immunodeficiencies, which could be exploited by different types of pathogens. An additional example of a post-treatment IAC would be a COVID vaccine injury. Connecting these issues to specific tissue compartments like the meibomian gland, which is an exocrine gland. How COVID-2 or other viruses like herpes viruses impact these glands. How workplace activities such as wearing a mask, an improperly fitted mask, producing dry eye disease in healthcare workers, making their eyes more susceptible to infections. All of these issues need to be integrated with using a flexible epistemology, not excluding the input of various stakeholders in the analysis of these disease states. These are some of the issues being addressed by the Long COVID Alliance, an umbrella organization which represents various stakeholder groups who have IX, infection-associated chronic conditions. One issue that the Long COVID Alliance could advance is the availability of low-dose naltrexone for the treatment of IX. Naltrexone currently has to be formulated in a compounding pharmacy to achieve the low-dose naltrexone dosages of 1 to 6 milligrams a day. This can be easily changed. Naltrexone could be formulated in LDN dosages in the form of tablets, droplets that can be put in liquids, nasal sprays, throat sprays, even transdermal formulations. Early in the pandemic, society was looking for low-cost, highly effective, small molecule therapeutics that could be easily scaled. Low-dose naltrexone is an example of a therapeutic which could be rapidly scaled for the treatment of long COVID as well as other IAC conditions. If you would like to download a PDF slide summary of this YouTube, which contains active links to PubMed references, news reports, and other YouTubes, you can find that PDF at this Google Docs folder, which can be accessed through the URL highlighted in green. In the last part of this YouTube, I will show links to related YouTubes that are on this YouTube channel. These appear on the subsequent slides. Once you arrive at the Google Docs folder, I encourage you to go to the subfolder Download First. This is where you will find an archive of PDF slide summaries of these presentations. Here are 4 URLs to recently posted YouTubes on this channel. These YouTubes deal with fast-acting vitamin D receptor agonists for the treatment of COVID. Calcitriol 125 vitamin D3 versus paracalcitol 125 vitamin D2. These are grouped in a series of YouTubes on specific subjects: paracalcitol for COVID, peroxisomes in COVID, as well as vitamin D receptor agonists and COVID eye infections. I also encourage you to view a MedCram YouTube by Professor Roger Schwelt, Light as Medicine. Vitamin D isn't enough. And here are some recent updates from the MedCram channel, including a case study, sunlight for a hospitalized COVID patient. Sunlight and near-infrared radiation can produce rapid inducible immunity and rapid inducible anti-inflammation. In addition to boosting the production of vitamin D3 in the skin, that is through UVA and UVB ultraviolet radiation, the near-infrared radiation components of sunlight provide important benefits for mitochondria, especially mitochondria which have been impacted by toxins, viral toxins, as well as metabolic toxins, as well as certain therapeutic drugs. Here is a short YouTube, only 3 minutes in length. It shows 5 vitamin D receptor agonists used for the treatment of COVID. These are among the top most important papers on PubMed dealing with this topic. These URLs are an index of the related YouTubes on this YouTube channel.